I am a trust grade neurology registrar. The job title is Senior Clinical Fellow of Neurology, but it's actually a trust grade neurology registrar job. Before I talk about the role of all of these artificial intelligence software packages in interpretation of imaging in hyperacute stroke, I would like to say that I have no disclosures or I don't have any conflict of interest. I have no affiliation whatsoever with any of these companies that have manufactured these software packages. It's just that I'm going to be talking about Brainomics and Rapid. The reason being that I've been exposed to these two software packages in my previous hospital, that is Kent and Canterbury Hospital. The artificial intelligence software package that was installed was Brainomics. And now that I'm in King's College Hospital, the software that we use over there is Rapid. So first of all, a little bit of introduction about what exactly is artificial intelligence. Artificial intelligence is a subspecialty of computer science, and machine learning is actually a subspecialty of artificial intelligence. Machine learning is actually whereby you train computer programs to learn from data in an intelligent manner. So it's actually one step further from one step beyond statistics. So statistics is just ordinary analysis of data, whereas machine learning is whereby you enable computational devices, including computers, to learn from the data. And there's basically a difference between the way traditional programming works versus the way machine learning or artificial intelligence works. In case of traditional programming, like for example, we think that computers only do what they are programmed to do. Like for example, we think that you give a specific set of instructions to a computer, and that specific set of instructions is the computer program, and the computer is trained to only execute that particular. You see, the program has been written by a programmer or a team of programmers, and the program is designed to take some input and then spit out some output, do some action. This is the traditional programming. And how is it different from machine learning or artificial intelligence? It is different in the sense that in case of machine learning or artificial intelligence, you don't explicitly or specifically program the computer to do something. The computer figures out what to do itself, just in an intelligent manner. Like for example, let me give you an analogy. Let's say you are designing a software that would calculate the prices of houses based on a few parameters, like for example, whether there's a front open space or not, the area of the house, the location of the house, blah, blah, blah. So conventional programming would be something like this. You give a formula, like for example, these are the variables, this variable multiplied by 7 plus this variable squared plus so on and so forth. This would calculate the price of the house. This is conventional programming, whereas machine learning or artificial intelligence works like this. The principle is that the computer is given some data, like for example, one house had this much of area and had a front open space in the front and was located in such a locality, and this was the price. Another house had these values for these parameters, and this was the price. Another one had this. This is the training data. The computer takes that. The programming, the machine learning program takes that, and then what happens is that there is a complicated software that learns by itself, and nobody knows what the intrinsic working of the program, including the programmer, because the programmer hasn't specifically programmed. So what happens is that basically the program learns by itself, figures out how to calculate, and then it learns from its own mistakes. It predicts the prices of new houses, And every time it gets an inaccurate result, it produces an inaccurate result. That inaccurate result is fed back into the system. And there's a complicated, like you can see over here, this is one particular type of artificial intelligence programming, which is known as a neural network. And the neural network is basically a concept in artificial intelligence or machine learning, which has been inspired by the human brain, actually. As you can see over here, all of these different nodes, these are similar to neurons, and the links between different nodes are similar to the synaptic connections between neurons. But here, these are not actual neurons. These are pieces of code. Now, how one code is how these connections are being configured, the software will automatically adjust the values of all of these. Every one of these nodes is actually a variable, and how one layer is feeding on to the next layer. The software hasn't been specifically programmed. Rather, it will adjust its parameters by itself in order to produce the accurate results. And when it gets an inaccurate result, it corrects itself. So this is actually the concept of machine learning or artificial intelligence. It is a lot more, for example, our email softwares filter out spam versus non-spam. The software has not been programmed. It learns by itself which email is spam, which email is not spam. When you open the mobile, when you open a camera in the mobile phone, it automatically recognizes faces and stuff like that. So it is a lot more prevalent. Now, moving on to the application in stroke and the imaging in hyperacute stroke. So these are all of the different statistics. It has been emphasized throughout the day that it's a major health issue and that it is causing considerable morbidity and mortality. I'm not going to repeat all of these statistics, but as you can see over here, lots of strokes happening, lots of more deaths happening as a result of that, and lots of morbidities and disability as well. And this has a huge economic impact as well. And in order to minimize this economic impact, urgent treatment and urgent intervention is necessary. And urgent intervention is necessary because the time is brain, and with every passing second, every passing minute, lots and lots of neurons are dying. And so in order to prevent that, if we are able to prevent that, this would reduce the socioeconomic cost or the socioeconomic impact. So for that, urgent administration of timely intervention of thrombectomy and thrombolysis is essential. And now the issue is urgent treatment requires identification of basically one of there are various links, links in this chain. There are various causes of potential delay, and one of them is interpretation of imaging, because someone has to interpret the images and find out whether there is whether this is consistent with the acute stroke or not. And so the decision of thrombolysis and then transfer to an expert center for thrombectomy, all of these are dependent on the findings of the imaging, and artificial intelligence can help with that. The reason being that it is instantaneous, and that we get the result, we get the interpretation the moment the scans are done. So basically, moreover, there's one other issue, which is highlighted by this figure. Now, as you can see over here, this is a study in which 300 physicians from 10 countries scored CT scans of 3 ischemic stroke patients. Now, these three patients had acute ischemic stroke, and 300 physicians interpreted the CT scan of these 3 patients. They used the diffusion weighted imaging MRI as the ground truth. For patient 1 had basically 1, 2, 3, 4. Patient 1 had an aspects of 4. Now you can see over here that I'm unable to see the numbers very accurately over here because but I think it's to 30, somewhere around 30 physicians out of 300 mentioned the correct aspect score, which was 4. In case of patient 2, about 95% of the patients mentioned the correct aspect score, whereas in case of patient 3, only about 5% of the patients mentioned the correct aspect score. So there is a lot of variability in the interpretation manual aspect score. So and moreover, there's you can see that this is the pathway or the guideline, the pathway for that we, if a patient is FAST positive and is suspected to have acute stroke, then we perform after taking a quick history and performing a quick NIHSS score, we go for a CT head and CT angiogram, and if needed, CT perfusion imaging as well, if that is if the patient is outside the 4.5 hours or 6 hours window, but is otherwise eligible for thrombectomy or under the DAWN or diffuse 3 criteria, then we go for CT perfusion imaging as well. And then the decision about whether to thrombolize or whether to go for artificial intelligence softwares kick in. And these are the different softwares. Brainomix is the software which was used in the hospital where I worked previously. Rapid is the software which is used in the hospital where I work currently. The other ones are Single Frontier, Avicina AI, Wiz AI, ADOC. So I'm going to be talking about Brainomix because this is the software that I've been most familiar with. So Brainomix is also available on your phone. Now you can see over here that in this patient, the artificial intelligence software has automatically detected that there's an area of acute hypodensity in the right putamen. And this is the kind of summary report that is generated by Aspects, and it is generated within seconds. I mean, the moment the scans are produced, the moment the scans are done, we get this. I mean, we can see these images. The stroke registrar on call can see these images while the patient is having CT scan or seconds after the patient has had CT scan. So the machine learning software or the artificial intelligence software detects it. And then there is a summary report as well. Like, for example, this is the summary report of one of the patients. It says that the total aspect score is 9. And this is color coding. The red is acute hypodensities. This one, the oblique lines, these are the non-acute hypodensities. So there's a 5 mil. It gives you the volume as well, that there's a 5 milliliters acute hypodensity on the right side. It gives you the total aspect score, and it tells you whether there are acute hypodensities as well as non-acute hypodensities. And it also tells you whether there is a hyperdense vessel or not. Now, similarly, this is the summary report for a patient who had CT angiogram. Most of the patients nowadays do have a CT angiogram because CT angiogram has now been incorporated into the routine imaging of hyperacute stroke. So you can see it gives you the collateral score. It gives you whether there is large vessel occlusion. It gives you yeah. So this is another one. You can see the collateral score is 3. It gives you the arterial input function as well as the venous output function. It is able to, now this is the color coding for the different arteries. It tells you whether it has detected free flowing blood in these arteries or not. And then it also displays the maximal intensity projections. As you can see, this is the axial maximal intensity projection. This is the coronal. This is the sagittal one from the left side, and this is the sagittal one from the right side. This is the marker for this plus sign. As you can see over here, this plus sign is the marker for arterial input function, and the minus sign is the marker for venous output function. I'm not exactly sure what does this mean. This is also included in the results of Brainomix. but I know that this has something to do with the phase of contrast administration.
2 more minutes for your
2 more
talk,
minutes.
please.
Okay, all right. So basically, I'm planning to do. I've started collecting data for a study to assess the accuracy of these artificial intelligence softwares. Basically, what I intend to do is that a neurology registrar who's blinded to the results of brainomics aided diagnosis and to the formal radiologist report. It's a retrospective study. I'm going to pull out the discharge letters from the stroke department for the previous 1 year. And I'm going to have a look at the patients who have brainomics computer aided diagnosis as well as radiologist formal report. And now I'm going to carry out this study myself. I'm going to have a look at the scans and I'm going to interpret to the best of my ability whether there is non-acute hypodensity or not, acute hypodensity or not, any large vessel occlusion or not. And then I'm going to compare that with what the brainomics said and what was the report of the radiologist. I'm currently working on it. It would take a few days more. And only 2 or 3 more slides left. While I was collecting data for it, the results will be compiled in about 15 to 20 days more. But while I was collecting data, I found out that there are sometimes some errors. Like, for example, in this patient, you can see over here that it tells you, no, not this one. Wait a minute. Sorry, this tells, not this one. You see, this blue means hyperdense vessel. So it is thinking that there's a hyperdense vessel over here, whereas there isn't any. In this patient, these are oblique lines. So oblique lines means that the software is thinking that there's a non-acute hypodensity over here, whereas this is only the Sylvian fissure. Similarly, there's one other thing that these softwares currently are heavily biased towards MCA territory infarct. So this patient had an ACA territory infarct and it mentioned an aspect score of 10. Whereas aspect score is 10 because aspect score involves MCA territory areas, but there was no mention whatsoever of this hypodensity. But just one last thing, and these 2 last slides. You see, if you remember a few years ago when Google started its speech recognition artificial intelligence software, which was used to automatically create subtitles for YouTube videos, the accuracy of the automatic subtitles on YouTube videos was pathetic. When you used to click on the subtitles button on a YouTube video, most of the subtitles that were automatically generated were nonsense. But over the years, it has improved. The reason being that artificial intelligence learns from its own mistakes. If it gets wrong, it produces a wrong result, then that wrong result is then fed back to the system and it takes that into account. And because there is no, it has not been formally programmed to do a specific thing, but rather it learns to do its own thing. So that's the reason why it gets better with time, like a fine wine. So hopefully, with the passage of time, the accuracy of this artificial intelligence will also improve. So this is the model that there's an input data, the machine learning algorithm or the artificial intelligence algorithm is created, and then that artificial intelligence algorithm takes in the input, does some prediction. Now that prediction is evaluated whether it's correct or not. If it's not correct, then it is fed back to the artificial intelligence algorithm, and then the artificial intelligence algorithm gets better the more it gets to practice. The more data it acts on, the better it becomes. So that was it. Thanks a lot.